HER2 protein dimerizing before it can do anything, it dimerizes and then it activates an intracellular molecular pathway that culminates in activation of the cell cycle and cell replication and all of that. Well, keep that in mind for this slide. I should rearrange the order of these slides. But a monoclonal antibody called pertuzumab specifically inhibits HER2 dimerization, right? So it prevents those single HER protein units from dimerizing. It sort of binds to it and it prevents those guys from dimerizing. So if they can't dimerize, they cannot activate the cell cycle, they cannot promote growth and all of that. And once again, all of the monoclonal antibodies that target HER protein or HER2 or HER2/neu, there are all these different names for it, are generally all for breast cancer and typically metastatic breast cancer. HER2 positive metastatic breast cancer, right? I mean, these won't do anything for breast cancer cells that don't express HER2, and some of them do and some of them don't. But if your patient has HER2 positive metastatic breast cancer, there are these various anti-HER2 monoclonal antibodies. Herceptin is usually the one of choice, the first one that people turn to, but then there are some fancier ones if the patient can't tolerate that or if that one doesn't work. And this one, pertuzumab, that specifically interferes with HER2 dimerization, is an innovative approach. Okay, so that was monoclonal antibodies. I have to talk about the programmed DEC ligand and programmed and PD-1 and PDL, programmed DEC ligand 1 and programmed DEC 1, and what that has to do with anything. So again, this is a slide that I inserted last night into the packet. I don't think it's in the Canvas set, but that's okay. Just sit back and enjoy it. Okay. So cancer cells are destroyed, kept in check by our immune cells, specifically by subclasses of T cells. Okay, and the cancer cells are really smart. They can express a protein called programmed DEC ligand 1, PDL1, that can interact with a receptor on the T cell known as PD-1, can interact with the receptor on the T cell and thereby prevent the T cell from doing its job of killing the tumor cell. I'm going to go that way because it's a bit confusing. So cancer cells express this protein called PDL1. And what PDL1 does is it sort of acts as a shield, preventing T cells from doing their job. Okay, so it will bind with a receptor on the T cell, which is called PD-1, and when the cancer cell protein, PDL1, binds to the T cell protein, PD-1, the T cell is not able to do its job. Its job is killing the cancer cell. So, and this is pretty recent stuff, in the last 15 years or so, investigators have come up with drugs that target this mechanism. The goal is to break up the interaction between PDL1 and PD-1. So there are drugs that target PDL1. They bind to PDL1 or they bind to PD-1, either way, preventing this bridge from forming. Does that make sense? So if we add something exogenously to saturate the sites, all of the PDL1 sites or all of the PD-1 sites, we will prevent this bridge from forming. And if we prevent this bridge from forming, we break that shield that doesn't allow the T cells to do their job. Okay? So there are drugs that specifically target this bridge, the bridge between PD-L1 and PD-1, they break it up so that the T cell is not blocked and the T cell can come in and kill the tumor cell, okay? And so there are monoclonal antibodies that do that, right? So you have a monoclonal antibody that is directed against the PD-1 receptor, so that would be like this orange triangle, directed against the receptor, which is expressed on the T cell, and that drug is called nivolumab, or Opdivo. It's useful for melanoma, lymphoma, renal cell carcinoma, and non-small cell lung cancer, okay? So I really want you to kind of understand the concept. So this programmed death surface receptor and programmed death ligand. The ligand coming off of the cancer cell, the receptor coming off of the T cell. When they bind, when they bind, the T cell cannot do its job, right? The tumor cell engineers this bridge that actually acts as a shield, preventing the T cell from doing its job. So the monoclonal antibodies break the bridge between PD-L1 and PD-1, allowing the T cell now to do its job. Keytruda, pembrolizumab, or Keytruda, is another famous monoclonal antibody that targets PD-1. So same thing. Sometimes these have been called checkpoint inhibitors, right? So again, it targets the PD-1, PD-L1 binding mechanism. It breaks up that bridge. It breaks the bridge between PD-L1 and PD-1, thereby destroying the shield that cancer cells erect against T cells, allowing the T cell to do its thing and kill the cancer cell. So monoclonal antibodies directed against the programmed death ligand and programmed death receptor are sort of the newest wave in immunotherapy, or among the newest agents developed for immunotherapy for cancer. This one was approved as recently as 2014, right? So less than 10 years ago. Anecdotally, it seemed to be really great at first. Keytruda, it helps. Patients are surviving longer than they did before Keytruda. It was touted originally as, sort of like a cure, like all these patients who were dying of these particular cancers, melanoma, squamous cell carcinoma, metastatic lung cancer, especially metastatic non-small cell lung cancer. Anecdotally, I can tell you people were helped with, but it wasn't a cure. People did end up, unfortunately, dying, but a little bit later with Keytruda. So we are still, looking for the cure-all, right? So a lot has been done, but we still have a ways to go. So, talking about immunotherapy still, that concludes what I want to say about monoclonal antibodies, right? So know about Keytruda, the PD-1 and PD-L1 mechanism, know about Herceptin, the antibodies that target the HER2 protein, know about the general concept of monoclonal antibodies for cancer. Then another type of immunotherapy for cancer that I mentioned are these so-called biological response modifiers. So this concept is the following. Instead of giving an antibody, instead of administering an antibody that's going to now be directed against an antigen and trigger some sort of mediated response that we discussed, whether it's activating the complement system, macrophages, or natural killer cells, or something else. Instead of administering a monoclonal antibody, we can administer something that is a general immune system booster, right? So we all have an immune system that recognizes foreign cells, that recognizes cancer cells, targets them and destroys them. What if we administer something like interferon gamma 2A to a patient that basically revs up the immune response against foreign-looking proteins? And that's the idea of a biological response modifier. So they're mostly interferons, which are interestingly molecules that are released in response to certain types of infection that rev up our immune system to protect us from those infections. Usually it's infections from viruses, but we can choose to administer these immune modifiers, these immune stimulants, I should say, these molecules that rev up the immune system. We can choose to give them. And of course, you know, the side effects, the patient feels like he has the flu, because when you have the flu, you release these interferons as part of your immune mechanism to neutralize virus, right? I don't know if this slide was made before or after the COVID pandemic, but you know, I would say the patient feels like he has the flu or a bad cold or COVID, because you're giving those interferons that are normally released when someone is infected with the virus. But what those interferons do is they rev up the immune system, so all branches of the immune system are accelerated and will hopefully target foreign antigens that are specifically expressed on cancer cells. And there are various biological response modifiers that one can do, that one can administer. They tend to be variants of interleukin-2, interleukin-2 alpha, interleukin-2 beta. Interleukin-2 is the big is the big interferon, is the big interleukin, I should say, interferon gamma 2A and interferon gamma 2B, along with interleukin-2. Those are the two classic biological response modifiers. They can be administered together, and they both rev up immune responses, that are going to hopefully specifically target cancer cells. So there are a couple of different ways in which, interleukin-2 can be administered directly. Another way of administering this biological response modifier, and this segues into our final discussion, which will be about CAR-T therapy, is that one can take lymphokine activated killer cells. One can take a particular subset of immune cells from a patient, grow them in vitro, add interleukin-2 to those cells in vitro. So you've revved up the patient's cells in the plastic dish, and then reinfuse the patient's cells into the body, right? So one way is just administer the interleukin-2 and hope that it circulates and revs up the immune system. Another is isolate the cells that you know are programmed to target the cancer, stimulate them in vitro with interleukin-2. And after stimulation, re-inject the stimulated cells back into the patient. This idea of taking cells from a patient and modifying them is a brand new idea in immunotherapy. We'll visit it again in a minute when we speak about CAR-T therapy, right? So this revelation came about 15 years ago, that a whole new approach to cancer therapy might be taking advantage of what the host does naturally, right? We know that the host protects us from microtumors all the time via something called immune surveillance, that our immune system all the time kills off little microtumors in our systemic circulation via different arms of the immune system. So this new idea is, let's take advantage of what the host does naturally. Let's rev up the natural immune responses that are anti-cancer responses and see whether these can form the basis of novel anti-cancer treatment. And so biological response modifiers is one way of doing that. Monoclonal antibodies is sort of another way of doing that. This is a particular special therapy that's sort of stuck in here, and this is the idea of proteasome inhibitors. So the proteasome is a large organelle inside your cells that is charged with the job of clearing away proteins that the cell no longer uses. It's actually a very important job. When the proteasome does not function normally, those proteins accumulate and they are toxic to cells, and they can actually cause problems in the cell, but that's a different lecture. So proteasomes clear away these proteins. It was discovered that if you inhibit the proteasome, you preferentially accumulate proteins that are pro-cell death, that are pro-apoptotic, pushing cancer cells to death, right? So I'm going to say that again. Proteasome inhibitors are a very specific type of modern treatment for cancer. By the way, they're specifically used for multiple myeloma. Mantle cell lymphoma perhaps as well. They are famously used for multiple myeloma, the proteasome inhibitors. The proteasome is an organelle that removes proteins from cells. So if you inhibit the proteasome, you will not remove pro-apoptotic proteins, pro-cell death proteins from cancer cells. They have a lot of them, or abnormal ones. In any case, the pro-apoptotic cells will then accumulate in the cancer cells, and the cancer cells will be pushed toward death, right? So proteasome inhibitors have a very specific mechanism that has to do with allowing pro-apoptotic proteins to accumulate inside cancer cells and thereby tipping the cancer cell in the direction of death. Whereas if you didn't administer the proteasome inhibitor, those pro-apoptotic proteins would be cleared away and there would be no signals for the cell to proceed to death. I think this is getting to the very last topic of this long unit that we have enjoyed, called cancer pharmacology or anti-cancer drugs or anti-neoplastic pharmacotherapy or whatever you want to call it. And the last thing I want to discuss is a branch of immunotherapy that is fascinating. I'm sure you've heard about it. It's been in the news, called CAR T-cell therapy, or chimeric antigen receptor T-cell therapy. Remember I said that the newest wave in immunotherapy is to take cells out of the patient, manipulate those cells in vitro, stimulate those cells in some way, give those cells new magical properties, and then re-inject the cells into the patient. Well, that's exactly what happens in CAR T-cell therapy. T cells are removed from the patient's blood. They are manipulated in vitro. So what is done is a kind of gene therapy. A gene that is normally not in those T cells is introduced into the T cell. That gene encodes a receptor for the cancer protein. Okay, so the T cells are taken out of the patient. A gene that encodes an antibody for the cancer cell antigen is introduced into the T cell. The T cell is grown up in a plate, and the T cells are reintroduced, are reinfused into the patient, and hopefully these manipulated T cells, called CAR T cells, target the cancer cells and destroy them. Very cool. Sounds so simple, right? But technically it was difficult to do. It took a long time to develop this therapy, and currently CAR T-cell therapy is being used at cancer centers throughout the world. It stands for chimeric antigen receptor T therapy, T as in T cells. So compared to, remember our evolution, right? Like I've said so many times, surgery, radiation, conventional chemotherapeutic agents, targeted chemotherapeutic agents, and then finally immunotherapy. So immunotherapy is the greatest hope. It's the most specific and least toxic. CAR T-cell therapy is considered so far the most promising approach to treating cancer. We've seen great results, up to 95% cures. et cetera, et cetera. So, I'm sure it's not the last word on cancer therapy, but CAR T therapy is probably the best that we have now, and there's specific types of CAR T therapy. So one has been used for ALL. Remember, the conventional chemotherapeutic agents for acute lymphoblastic leukemia have been great, right? We talked about the evolution of treatment for ALL and how it used to be a death sentence, and how with the advent of even conventional chemotherapy, the prognosis is so much better. With CAR T therapy, we're seeing near perfect results in terms of prognosis and cure. Another one for another type of hematopoietic malignancy, large B-cell lymphoma. Remember, all of these are the same underlying concept, right? The T cells are removed from the patient. The gene for a particular antibody is introduced, and so that's important. So what gene you introduce into the T cells, what antibody it's going to produce is important. You need to choose the right antibody that's going to effectively target the cancer cell. But this one has been very effective for adult patients with large B-cell lymphoma. There's a commentary on this slide. I didn't actually write this, but I inherited this slide. I'm not saying I agree or disagree. It's a little bit political, but I will say that, yeah, so that's the problem with this fancy immunotherapy and CAR T therapy, et cetera. It's been said America is the greatest place in the world in terms of innovation for drug therapy and great drugs and interventions that we have for various illnesses. What we're not very good at is healthcare delivery, right? CAR T therapy is fantastic, but it costs $373. It might cost $500,000, and insurance will not cover it all. So that's the next problem, right? Now that we know that CAR T therapy works pretty well, how do we make it inexpensive? How do we get the cost down from like $500,000 to $50 or something that patients can actually afford, or something that can be covered by insurance? So this is a mean question. Rituximab, remember that was the first monoclonal antibody to be approved for the treatment of cancer. It is genetically engineered, humanized monoclonal antibody directed against CD25, so it's directed against CD20. I won't, so it's false. I won't be that mean on the test, sorry about that. But anyway, that's it. Here's the list of drugs that you should know, pretty much. Going beyond this, I will really emphasize those drugs that I spoke a lot about with my greatest enthusiasm, and all of that. Let's see, how are we doing? Yes, don't go anywhere, we still, oh, no, wait, it's 4:46. Oh, yeah. We end what, at 4:15? Okay, so we didn't really get to do heavy, that's fine. Yeah, so